Hello, everyone. My name is Mickey Voss. I'm one of the endocrine faculty here. In this lecture, we're going to focus on type 2 diabetes, diagnosis, management, and we'll spend a great deal of time on pharmacology. Admittedly, I've put a lot of extra information on these slides. I'm not going to have time to talk about everything, but I've left it here for your review. And then if you have questions after going through this lecture, please feel free to reach out to me. I've left my email on the last slide of this presentation. And these are my objectives. I'll leave them for you to review. When we talk about type 2 diabetes, I think everyone listening is well aware that type 2 diabetes is an ever-growing public health crisis. There's expected to be around 640 million people living with type 2 diabetes by 2030. This affects around 12% of the US population, around 9% of the population of Wisconsin. Our people are living with type 2 diabetes, and around a third of people in Wisconsin are living with prediabetes. So this is a problem that's not going away anytime soon, and something that we desperately need to get ahead of, which we are struggling to do. So over the next two slides, we're going to talk about just in general the pathophysiology of type 2 diabetes and just a quick review, right? So there's two main problems for type 2 diabetes. It's insulin resistance, where insulin concentrations are inadequate to maintain normal glucose levels. And then later on, you can develop an insulin deficiency, whether this be relative or a complete deficiency due to the beta cells becoming non-functional due to glucotoxicity and lipotoxicity and eventual failure. And this graph down here is just sort of a point that drives home that many people who have prediabetes have had prediabetes for many years before they develop type 2 diabetes. And what you can see is that over time, many years, blood sugar levels can start to rise. And alongside that, insulin levels are rising to be able to try and keep glucose levels normal. But at certain points, you reach a threshold where you're no longer able to keep up with the amount of insulin resistance that's developed. And then you may see over time, insulin secretion may deteriorate again as beta cell dysfunction worsens and or develops failure. This is a busy slide. It's really just here to illustrate that obviously diabetes is affecting many different organ systems, and many different players go into the development of hyperglycemia. We don't obviously have time to talk about the pathophysiology and development of type 2 diabetes in its entirety for this lecture, but just to remind you that this is obviously multiple organ systems are involved here. When we talk about who's at risk for developing type 2 diabetes, right? So people that are 45 or older was sort of what we used to think about. Unfortunately, we know that type 2 diabetes is on the rise in much younger patients. Children are getting diagnosed with type 2 diabetes at really an alarming rate. And so we need to be mindful of that. Certainly people who are overweight or obese and then have other comorbidities that run in line with type 2 diabetes, as well as family history. Race, ethnicity certainly plays a role, of course, sedentary lifestyle and poor diet. But a couple that I want to really highlight are patients who've had a history of gestational diabetes are extremely high risk for developing type 2 diabetes later on in life. And then patients with polycystic ovarian syndrome or PCOS also have very high risk of developing type 2 diabetes. So we need to screen those people more aggressively. When you're seeing patients in clinic, things that you might notice that might clue you into either being worried about either prediabetes or developing type 2 diabetes. So patients may comment on having fatigue or increased appetite, certainly if they're obese or overweight. They're developing weight loss alongside, polyuria, polydipsia, the classic signs of developing diabetes and hyperglycemia. If they're having recurrent infections, either UTIs or yeast infections due to the glucoseuria that develops in diabetes. And then certainly acanthosis nigricans or skin tags can develop as well. And as I mentioned on the last slide, this is just an example of what you might see in patients with severe insulin resistance, which is really what acanthosis nigricans is indicative of. So you can see very dark velvety sort of skin, as well as numerous skin tags. In terms of the diagnosis of diabetes, we covered this in my other diabetes lecture, so I'm not going to belabor the point, but remember there's multiple different ways we can diagnose diabetes, and here are the cutoff criteria for making the diagnosis. I do, however, want to highlight the criteria for prediabetes. Okay, so these are people that obviously are at risk for going on to develop type 2 diabetes. And the reason that I want to highlight this is because these are the people who we need to really intervene on aggressively and early to hopefully stave off developing full clinical type 2 diabetes where we need to additional therapies or be more aggressive later on with medications. So anyone with an A1C between 5.7 and 6.4%. If they have a fasting plasma, not a finger stick point of care glucose test, but a fasting serum glucose level of 100 to 125 milligrams per deciliter, or they have a 2-hour plasma glucose tolerance test between 140 and 199 milligrams per deciliter. Obviously, we predominantly use options 1 and 2, but you can use option 3 as well. And again, who do we screen, right? So in patients who are asymptomatic, of course, the ones that have risk factors that we talked about, if they have physical exam findings as we discussed, but those who have chronic HIV, pancreatitis, or other medications that are either associated with comorbidities that run in line with diabetes, or certainly medications that we use that do cause hyperglycemia. For those, of course, who are symptomatic or very high risk, we need to be not just screening those people, but intervening. But these are people who you want to screen more frequently. When we talk about how often to screen, so for those who have prediabetes, usually annually is appropriate. Although for those who have rising levels or who are very close to developing meeting the criteria for type 2 diabetes diagnosis, you want to screen them maybe every 6 months or a little bit more often. For those individuals who have a history of gestational diabetes, every 1 to 3 years, again, is reasonable to start with. But again, those who are approaching closer to the diagnosis of type 2 diabetes, you want to screen them more frequently. Anyone 35 or older, chronic HIV or other high-risk groups, as we mentioned. And every couple of years is probably reasonable for those who've had stable levels. And again, you can adjust your frequency as needed. I want to mention the long-term complications of diabetes. No diabetes lecture is complete without talking about them. We're not going to spend a ton of time on them, but I want to focus on preventing these from developing, but certainly keep in mind the complications to monitor for in all of your patients with diabetes. Microvascular complications being retinopathy, having their eye exams, nephropathy, screening urine protein, neuropathy, doing foot exams, looking for peripheral neuropathy, as well as screening for autonomic gastroparesis and other neuropathies. Of course, macrovascular, atherosclerotic cardiovascular disease, again, coronary artery disease, MI is the #1 cause of mortality in patients with diabetes. Stroke, peripheral vascular disease, of course. And then there's some other things that we want to keep in mind as well in terms of osteoporosis and fractures, certainly metabolic associated fatty liver disease. And just in terms of the burden of diabetes, keeping in mind that the management of diabetes is a patient-centered, patient-driven disorder. And so the burden that is placed on the patients can certainly lead to depression, anxiety. And then we do know that, of course, patients with diabetes have a higher risk for dental consequences as well. So making sure they're getting regular dental screenings as well. Of course, what we hope to prevent is all of those complications. And how do we do that, right? So early and appropriate screening plus aggressive interventions, right? And we've talked about that a little bit, and we'll talk about it more here in the coming slides. Certainly, glycemic control is paramount. That's been the cornerstone of managing and helping patients with type 2 diabetes, as well, any diabetes for that matter. Blood pressure control, certainly optimizing their cholesterol levels, physical activity, and dieting. So I'm not going to spend a ton of time talking about this, but we can't forget about this, okay? So, getting patients to get their recommended, 150 minutes of moderate intensive exercise, as well as sort of working on healthier dietary choices, okay? We forget about this, even picking 1 or 2 goals at each visit and setting SMART goals where you can really hold them accountable is very, very useful. Okay, not I'm going to eat better, I'm going to exercise more. Okay, well, how many days? How many minutes? What are you going to do in a week? What can you do that's reasonably achievable over the next couple of months, right? Is it cutting out bedtime snacks, 2 times a week only, right? Instead of every night. Things like that can be very, very helpful and make a huge difference. We talked about the diabetes control complications trial for patients with type 1 diabetes. Here are three um, trials looking at glycemic control. Again, I've put the DCCT and then the two studies that were sort of the cornerstone in proving that better glycemic control leads to decreased risk of complications in type 2 diabetes as well. We talked about glucose monitoring in patients with type 1 diabetes, but we're going to talk about it again here. When we monitor our interventions, right, remember that, of course, A1C is a very useful tool and something that we've used now for decades as our cornerstone in terms of our gold standard for achieving glycemic targets in patients with type 2 diabetes. But remember, it's not always reliable. So keep in mind if they have anemia, hemoglobinopathies, chronic kidney disease, the A1C may not be reliable. So remember, we do have some other alternatives. Of course, you can use point of care glucose testing and continuous glucose monitoring data, which we'll review here in a second. But there's also another entity called fructosamine. This is glycated albumin, and I've put sort of the comparisons between fructosamine levels compared to A1C levels. So you can use these in patients who have issues that make A1Cs less reliable, and you can kind of correlate it and see if they're accurate to see if it's a useful tool or not, and kind of guide how we're doing with our interventions for diabetes care. We reviewed briefly glucometers and point of care glucose testing in the other diabetes lecture, so you can refer back to that. This is just an illustration to show you what it looks like when patients are checking their blood sugars. Obviously, there's variations of the different devices that can be used, but just be aware this is kind of what it looks like when patients are checking their blood sugars. When we talk about the different options for glucometer brands, there's a lot of different brands that are out there. This is a busy slide. You're not expected to remember any of this, obviously, but be aware that there's good meters and there's bad meters. And this is even kind of an old study. It's almost 8 years old now, where they looked at all of sort of the main brands that were on the market. And a lot of these have stayed. Some of these we still use today. Some of these obviously don't exist anymore. But what you're looking for is you want a good MARD, or mean absolute relative difference. Basically, what it's comparing the glucometer to is venous blood sugar levels when they're measuring it through an IV in the lab, and they're comparing what the difference is. And so a MARD of less than 10% is a good sign that the meter brand is accurate. And you can usually find this online or on the package inserts, but just be aware that not all meters are created equal. We also talked about continuous glucose monitors, or CGM. This is used much more readily now in patients with type 2 diabetes, as really any patient that's on insulin can utilize these systems. As you heard me say in the other lecture, I think anyone with diabetes should be able to be on these systems, but unfortunately insurance is not always in line with that. But certainly if you can get patients on a CGM, we know that just wearing a CGM alone will help improve glycemic control. Because it shows patients what's happening in regards to their meal and exercise, which is super important and very, I think, enlightening for patients with type 2 diabetes when they see what happens when they eat that pizza or candy bar or drink soda or go for a walk or a run. I think it can be very habit changing and lifestyle altering for them, to really show them what's happening to their blood sugars when they're doing things like healthier diets and regular exercise. One other thing I want to mention quick is that our glycemic targets are not the same for all of our patients.
Moving to sulfonylureas and meglitinides, these work very similarly. They just bind to different parts of the receptor, but the end result is they increase pancreatic insulin secretion. And then I've given you a chart looking at the different doses and half-lives as well as duration of action. Really, the big difference between sulfonylureas and the meglitinides is the meglitinides are a little bit shorter acting compared to the sulfonylureas. And so we dose the meglitinides more with meals as to compared to the sulfonylureas, which you can dose once or twice a day typically. Main side effect of these medications is really hypoglycemia. It's fairly common. You should be careful using these in patients with impaired renal function due to decreased clearance, particularly in older patients who are at risk for falling. Certainly, with increased insulin, you're going to see some weight gain, and some of these other things are pretty rare. Never seen them myself, so. Thiazolidine diones, or TZDs, as I'll say from here on out. These work through the PPAR gamma receptor. They're really insulin sensitizers, particularly in the adipose and muscle tissues. Main side effect is weight gain and fluid retention, so we want to avoid these in heart failure. Be aware that they also can cause increased risk of fractures. And I alluded to this earlier. Pioglitazone has been shown to lower non-fatal stroke and MI, and rosiglitazone was the one that was taken off the market due to increased cardiovascular mortality. Next couple slides, we're going to talk about some medications that we don't really use a lot of. Alpha glucosidase inhibitors, acarbose or meglitol, they basically just impair glucose absorption in the GI tract. We really don't use them because they're weak and they have a lot of really kind of nasty GI side effects, so they're not used all that often. The DPP-4 inhibitors, we used to use these a lot. They're nice because they're once daily pills. I've listed off the most common ones here. They don't provide any additional cardiovascular or renal benefits, and really they're fairly weak in terms of their glucose lowering effects. And so, because they still cost a fair amount as well, we really don't use these all that often anymore. This is just to be aware of the mechanism of DPP-4 inhibitors. Remember that there's a peptidase, dipeptidyl peptidase 4, that breaks down GLP-1, and these inhibit that peptidase to prolong the endogenous GLP-1 effects. They're very well tolerated, but again, they're pretty weak. And then amylin analogs, I mentioned this a little bit in the type 1 lecture. Amylin's a protein that is co-secreted by the pancreatic beta cells with insulin, and there are its effects. And pramlintide is approved in type 1 diabetes. We just don't use a lot of it because it requires an injection with each meal, and if patients are on insulin, it's really increasing the number of injections. And due to its sort of weaker effects, we really don't utilize this all that often. Now moving into medications that we use all the time now, which you've heard of, the GLP-1 and or GIP, and then we'll talk about SGLT2s in a couple slides. So GLP-1, glucagon-like peptide 1, it's a short-acting GI peptide that is secreted in response to eating a meal. And it does a couple different things. It augments insulin secretion. It does have central nervous system effects in terms of decreasing appetite, and then it also delays gastric emptying. The combination medication, which is Mounjaro, Zepbound, is also has glucose-dependent insulinotropic polypeptide, which is co-secreted with GLP-1, and it really just amplifies GLP-1 effects. I'm not going to go through the mechanisms of each of these hormones specifically. I've laid them out for the table for you in the table below here. So let me know if you have questions on this. This is a busy slide. It's an ever-growing family of medications. The GLP-1s, obviously, they're in the news and the media all the time. I'm going to focus on the ones that we use most often. We started with daily injections. We've now moved into long-acting injections that are given once a week. The workhorses in this group are dulaglutide or Trulicity, semaglutide, Ozempic. These are GLP-1 only agents. They have very potent A1C lowering and weight loss effects, plus the cardiorenal benefits that we have discussed in terms of lowering cardiovascular risk, as well as with semaglutide, the injectable version, Ozempic only, also lowers risk of renal disease, renal progression from diabetes damage. And then the dual GLP, GIP medication, of which this is tirzepatide, Mounjaro, for diabetes care. This is the most potent A1C lowering agent we have short of insulin, and certainly has additional weight loss effects as well. Be aware that Mounjaro at this point does not have cardiovascular benefit data. That study finished actually last year now, so hopefully we'll be getting that data soon. But just be aware that that does not have that benefit at this time. In terms of side effects, mainly GI gut related, so nausea, vomiting, diarrhea, constipation, abdominal pain. Try to be careful of using these in patients with gastroparesis or delayed gastric emptying. Pancreatitis is a real entity. Okay, we tend to avoid using these in patients with a history of pancreatitis unless their provoking factor is very clear and now resolved. There's been some concern about other things in terms of pancreatic cancer. That seems unlikely. We don't use these in patients with a history, either personal or family history of medullary thyroid cancer or multiple endocrine neoplasia, although I will tell you that we have not seen an increased incidence of this in humans, and this was born out of animal models, so just be aware of that. And these are not approved in patients with type 1 diabetes. However, we use them fairly frequently, and this may change in the future, but for now, it's not approved in type 1 patients. And then the other newer agent class is the SGLT2 inhibitors. Remember, these are affecting glucose reabsorption in the proximal tubule, which normally very efficiently reabsorbs glucose. And these block that membrane transporter, which leads to increased glucoseuria and decreased plasma glucose levels. Remember that this is GFR dependent, so in patients with CKD and impaired renal function, these are not as effective in terms of glucose lowering. It also helps with fluid losses, so it does help a little bit with blood pressure. And there is no direct effect on these with insulin secretion or hepatic or renal glucose output in terms of gluconeogenesis. All of these are oral medications that are taken daily. I've listed out the names of the currently available agents and the dose ranges. Use is not recommended in those with GFRs less than 30. These do tend to increase genital yeast infections or urinary tract infections because obviously glucose is a nidus for microbial growth, excuse me. Fournier's gangrene does happen. It's necrotizing fasciitis of the perineum. It's rare, and particularly rare if people are maintaining good normal hygiene. So it's important to talk to, and for most people, this isn't really a big concern. Do be aware, though, of euglycemic DKA. I mentioned this in my other lecture. You should not be using these in patients with type 1 diabetes or in patients with type 2 diabetes who are prone to getting DKA because these do increase risk of DKA in a non-insulin mediated fashion. So be aware of that. And this is just a summary slide reviewing the different potencies in terms of glucose lowering and A1C lowering of the different agents that we've just talked about. So metformin, which we use all the time, about 1 to 2%. Moving down to some of the other ones that we use more frequently, SGLT2 inhibitors, really mainly for the cardiorenal benefits, but only about 1% really at most for A1C lowering. The GLP-1s, of course, 2 to 2.5%, and I should even put a plus next to that because many times it does lower A1Cs even more than that due to its effects on appetite control. And then certainly we were going to talk about this in the next couple slides. Insulin therapy, there really is no limit. These are the most potent A1C lowering agents we have, and we can always give more insulin to be able to bring sugars down more. So we'll talk about insulin therapy here coming up. Moving on to insulin therapy. So again, there's some overlap with my other diabetes lecture, which I encourage you to review as well, because we talked about insulin dosing in that lecture as well. But just to sort of highlight some of the differences for patients with type 2 diabetes, they tend to have obviously a little more insulin resistance, so their weight-based dosing or total daily dose is a little bit higher compared to patients with type 1 diabetes. Remember that basal insulin dose is about half of the total daily dose. You can use the 500 rule to calculate out mealtime doses, and you can convert this to fixed dosing as well, and dose it based on their breakfast size, lunch size, and dinner size, or You can certainly have them have doses for small, medium, large meals and or snacks. And then the 1700, 1800 rule calculates that correction factor in terms of how many units or how many uh, points in blood sugar milligrams per deciliter that 1 unit of insulin will lower their blood sugars. And again, review the type 1 diabetes lecture for more of a complete insulin pharmacology. I do, however, want to highlight the pre-mixed insulins as we tend to use these a fair amount more in patients with type 2 diabetes. I've given some sort of starting parameters for how we dose these, and keep in mind, right, these have typically NPH, which is a little bit longer acting, 8 to 12 hours, and a short-acting insulin, whether it be regular or one of the analogs. And really what these are designed to do is to minimize the number of injections for patients so that you have coverage of both basal insulin as well as mealtime coverage with one injection. So you'll get sort of these peak effects early on, which will also cover that second meal after the morning dose. And then when they give their second injection after dinner, it will still cover them their basal insulin needs overnight. Obviously, there's limitations to these, but certainly it helps patients cover their daily insulin needs better with a minimal injection. And just a quick mention of U500. So this really is done in the endocrine clinics. This is not done in the primary care clinics or by the general hospitalists. But you need to be aware of it. So it's an ultra concentrated insulin. It's really only used in severe insulin resistance and in patients who require more than 250 units of insulin a day. This also is basal and bolus insulin, so they shouldn't really be on any other insulins at the same time. And you can kind of see the pharmacokinetics of when they're giving injections, usually 2 or 3 times in a day. And they give it at breakfast, and then there's a slow taper throughout the rest of the day. They give it at lunch, where they have a peak during their meal period, and then a slow taper, and then the same thing for dinner. You can do 1 or 2 or even sometimes 4 injections for some people, and just be aware of that. This is very concentrated, and so the number of units now in the pens are the same. If you see vials, you need to recognize that the units may be very different and can be very dangerous, and so really you should be involving a specialist when dosing it in that manner. And then just I want to quick mention some additional therapies for patients with type 2 diabetes, and this is going to be a growing area here over the coming years. So I just want you to be aware of it. So we talked about insulin pumps. Typically we think of those as modalities that we use in patients with type 1 diabetes. However, there are 2 insulin pumps that are now approved for use in patients with type 2 diabetes. So you're going to start to see more and more of that. And I think it does really improve quality of life. The other thing I will tell you is that for patients who have told us for years, oh, I'm taking, this number of units of insulin, and they're on high doses, and we put them on a pump, and the pump is sort of controlling their insulin delivery, we actually see their insulin requirements at much lower of a dose than we would have expected for what we had prescribed previously because they're just not taking it. So be mindful of that. Certainly, pancreas or islet cell transplantation in very specialized patients and obviously requires immunosuppression and has its associated complications. And then inhaled insulin, so it's the fastest onset. Afrezza is the only currently approved insulin that's inhaled. Certainly, there's concern for lung function and long-term cancer risk, but you may come across this at one point or another. It's dosed very differently compared to the injectable versions, and they come in cartridges of different sort of strengths, and so not used very often. I've had a few patients in my career that have been on Afrezza, but it's pretty few and far between. And finally, as we wrap up, so I just want to leave you with a few kind of clinical pearls for type 2 diabetes care. So you can never forget about lifestyle modifications. The foundation of managing and helping patients with type 2 diabetes is really diet and exercise. You have to start there. You can tailor your glycemic targets to patients with the goal of minimizing hypoglycemia. Certainly our younger healthy patients be more aggressive, and those who are at risk from hypoglycemia or have hypoglycemia unawareness, we want to loosen our glycemic targets. We want to shift the agents that we're using to focus on agents that have cardiorenal benefits, but still don't forget about metformin. Okay. Metformin doesn't have any benefit data, but it also doesn't have any harmful data either. And then when able, use, CGM therapy in patients who are on insulin with type 2 diabetes, and you can certainly consider insulin pump therapy as well. I'll stop here. I want to thank you for your attention. If you have any questions, please feel free to reach out to me. My email's on this slide. I'd be happy to answer any questions you have. Thank you.